for having me. I'm sorry I could not be there in person today. With all that we're learning about the relationship between inflammation and many neurodegenerative diseases, and more recently, the impact that COVID-19 has on the brain, it may not be surprising that very early on in the AIDS epidemic, some of the most pronounced presenting symptoms were actually neurological symptoms. And then came the corresponding neuropathological postmortem and MRI findings, particularly in subcortical structures of the basal ganglia and the white matter. So HIV dementia was initially characterized as a subcortical dementia. But there has been immense progress in access to and efficacy of antiretroviral therapy, or ART, which has ultimately created an epidemiological shift in HIV from a disease that was inevitably fatal to a chronic one which patients can actually manage. Despite widespread access to ART, neurocognitive impairment is a persistent issue in people living with chronic infection, and it's estimated to be present in up to 50% of cases. There's great interest in understanding factors contributing to the ongoing broadening spectrum of neurocognitive impairment, particularly the most mild forms. And of the potentially contributing factors noted here, I think of particular interest are the neurodegenerative processes that can occur with aging. Because near normal longevity with treatment means that for the first time we have an overall aging infected population. So in the US, for example, an estimated 70% of people with HIV are over the age of 50. So again, there's great interest in understanding infection in the context of aging and how and if they interact. The broadening clinical spectrum of HIV may in part reflect the aging population, but may also be a reflection of other sources of heterogeneity in the infected population. Like most diseases, there are a host of factors that may impact symptoms of brain dysfunction, such as socioeconomic factors, treatment regimens, and other comorbidities. And this heterogeneity is not surprisingly reflected in the inconsistent findings coming from relatively small single cohort neuroHIV studies that are published, which make it hard to identify HIV brain signatures that generalize beyond these individual studies. And that's why initiatives like the ENIGMA consortium are so incredibly important. For those that may be unfamiliar with ENIGMA, it's an initiative to power large-scale analyses of various neurological or psychiatric disorders by pooling together existing data across international institutions and studies, using harmonized pipelines to identify disease effects that can be reliably found across these participating studies. So over the last few years, we have put together an HIV working group with data from diverse sets of pre-existing HIV cohorts from all around the world. One of the most frequent neuropathological features of HIV encephalopathy was this diffuse white matter pallor from demyelination and axonal injury. So there have been a number of diffusion MRI studies published investigating effects of HIV on white matter microstructure. But as we said, there is tons of heterogeneity in the findings from these studies. So our goal here was to pool diffusion MRI data from independent worldwide neuroHIV studies to identify generalizable white matter microstructural associations with infection using standardized data analysis pipelines. The ENIGMA-HIV DTI working group is currently made up of 10 neuroHIV studies from the US, South Africa, Australia, and Serbia. In total, dMRI data from 840 people with HIV were analyzed, spanning 20 to 80 years of age, a majority of whom were male and on ART. And also we included 280 HIV negative controls, but these were only collected from a subset of 6 of these studies. And what this table shows is that there's both clinical and diffusion MRI variability across the data sets. After diffusion data were processed, DTI anisotropy and diffusivity maps were computed, in addition to a more advanced diffusion model version of FA called TDF-FA, which accounts for crossing fibers unlike DTI. Using the standardized ENIGMA-DTI protocols, each subject's diffusion measures were projected onto the ENIGMA-DTI template skeleton using TBSS. And then mean measures were extracted from 24 JHU white matter atlas regions of interest, as well as the full white matter skeleton. Random effect linear regressions were performed to evaluate associations between regional diffusion measures and 1, HIV diagnosis when compared to controls, or 2, blood plasma markers within people with HIV. And these included current CD4 T cell count and a detectable or undetectable HIV viral load. We also tested for diagnosis or plasma marker by age interactions, as HIV may accelerate age-related effects on white matter microstructure. Study was used as the random effects grouping variable. Fixed effects covariates included age, sex, and their interaction. Statistical models testing for plasma marker associations within people with HIV also included ART status at the time of scan as a covariate. And then the false discovery rate was used to correct for multiple comparisons. We found lower anisotropy and higher diffusivity measures were associated with an HIV diagnosis when compared to controls, and with lower CD4 T cell counts reflecting immunosuppression. Widespread regional associations were detected across all diffusion MRI measures except DTIFA, which is shown in the second row of these figures. Significant full white matter skeleton associations were also found, suggesting global white matter effects. So to identify regional effects beyond the global white matter effect, we additionally covaried for the full white matter. The largest regional associations with diagnosis, which were found in regions of the corpus callosum, corona radiata, uncinate, and fornix, remain significant when covariing for the full white matter. And these associations are indicated by the darker opaque bars in the figures. The largest effect sizes for CD4 associations were found in regions of the tapetum, corona radiata, fornix stria terminalis, but in this case, only the fornix and tapetum axial diffusivity was significant beyond the global white matter effect. We also note that because most people with HIV were on ART, results were similar when analyses were limited to participants on treatment. Widespread regional HIV diagnosis by age interactions were also detected, this time across all diffusion measures except axial diffusivity. Only the tapetum was significant across diffusion measures. The full white matter and tapetum scatter plots, which are shown here, show steeper negative anisotropy and positive diffusivity slopes with respect to age in people with HIV compared to controls. The largest effect sizes were again found in regions of the corpus callosum, tapetum, and fornix stria terminalis, which also all showed significant effects beyond the full white matter effect. We did not find any HIV plasma marker by age interactions. So in a large-scale international population of people with HIV, widespread white matter microstructural abnormalities were consistently associated with HIV infection and immunosuppression. And while effects were often global, larger effects were detected in limbic and temporal lobe tracts that are often implicated in aging and neurodegenerative conditions such as Alzheimer's disease. And these results are actually consistent with the results from our first ENIGMA-HIV publication, evaluating plasma marker associations with subcortical volumes in 1,200 adults with HIV, who again were largely on treatment. In that study, we found lower CD4 counts and detectable viral loads were associated with smaller limbic structures, in particular the hippocampus, rather than the expected basal ganglia associations that were a hallmark of pre-ART studies. And then we also only found basal ganglia associations in individuals not on treatment. So this suggested to us a shift in the profile of HIV-related brain abnormalities in the ART era. So coupled with significant HIV diagnosis by age interactions in white matter microstructure, our results support evidence that common age and HIV-related pathological processes, for example, inflammation and blood-brain barrier impairment, may accelerate may accelerate age-related neurodegenerative processes. I'd like to say thank you not only to our collaborators, but the participants, their families, and the many people that make these team science projects possible. And a quick plug here that if you'd like to either contribute data to this initiative or lead a study of your own using these data, please do reach out to us. We'd love to hear from you. And definitely reach out to me if you have any questions. Thank you so much for listening.